You have to see if you recognize the movie and the singer as well. Okay. Or the artist on that blue sheet. Okay, I'm very pleased and honored to welcome our next speaker, Professor Lisa Johnson. Many of you may know her. She's been a professor at Stony Brook University for a long time. I've been very impressed with her work. We met years ago. She's held different positions, clinical director, professor, and now program director of the respiratory care program at Stony Brook University Hospital. Please welcome Lisa Johnson. So nice to see you.
Good morning. All right. I'm hoping that this time with you will be an interactive time. So I have a couple questions for you, and I'll just start with the first question. How many people in here work in a neonatal intensive care unit more than 5 times a month? Okay. All right, so for those people who work in a unit more than 5 times a month, as I go through the different cases, if you would like to share your experience with a case similar to this, I would be happy to hear it. One of the things that I'm going to share with you today when it comes to these different case presentations that I have, these are a combination of cases that I have seen throughout my career working in respiratory, which has been like 30-something years now. And so I've combined a number of different cases, a number of different situations to come up with simulations that I utilize in a classroom setting. So as we go forward, what I would like for this to be is an interactive type of situation. So here we go. So this is our first case. This is Baby Bean, right? So Baby Bean, you are the neonatal therapist working the day shift at a large metropolitan hospital. You're called to the delivery room for a preterm neonate. As you arrive in the delivery room, the infant is being placed on the radiant warmer. So now what you need to start thinking about, okay, now that I'm here, I'm at this large hospital, and I'm coming into the delivery room, what do I want to know about what's going on? So these are some things here, and I just want you to take a few minutes and take a look at it. Like, what information would you need to assist in evaluating this infant? And just, if you have a piece of paper, write it down and whatnot, because I'm going to pull some of the answers up in just a few minutes. Because when you walk into that delivery room, there are things that you need to know about that baby that's going to help you manage that particular baby when you get into the delivery room. So think about, what would you want to know about this baby that has been placed on the radiant warmer? Right? And that's going to help you manage this particular baby at this point in time. So I'm just going to wait 1 minute, and then I'll kind of keep talking. The hardest part when you go into the delivery room is that if you don't come in with any information whatsoever, if you just get a call to say that the delivery room, there is the delivery room, and we need you over there now, and you're running over that way, and you get into the delivery room, you walk into that room, and you're like, okay, what's going on? I need to be able to know what's going on. Sometimes you get information ahead of time prior to walking into the delivery room. So let's check the heart rate. You do need, sorry about that. All right, so you do need a heart rate. All right, you definitely need to know what your heart rate is for this particular baby. So it's 92 beats per minute. If you think about neonatal resuscitation, anything less than 100, there's an action that you should be taking at this point in time. The LS ratio, well, the LS ratio, you ask, what is the LS ratio? And they say it's 1.2 to 1. So if they got an LS ratio, that will probably tell you that this baby is a premature baby. What exactly is the gestational age? You don't know at this point in time, because anything less than 1.5 indicates that the lung is immature. There's a lack of surfactant. Respiratory effort, the baby's gasping. So right now the baby's kind of struggling to breathe at this point in time. Electrolytes, well, you're in the delivery room. You're not going to need them. You're not going to need them at this point in time. So I put down as not obtained. The muscle tone, the baby's limp. So the baby's come out and the baby's just laying there. Okay, I'm here, I'm out, I don't want to be out, but I'm here. So there's not a lot of movement of the arms or the legs whatsoever. I can't get this in. Gestational age, 30 weeks. Right? So From the LS ratio of 1.2 to 1, you kind of had an idea that the baby was premature, but you weren't too sure how premature this particular baby was. Turn around this way. Color, acrocyanosis. Remember acrocyanosis, your extremities are pink. Your extremities are blue and your body is pink. So that's not a sign that there's really poor oxygenation at this point in time. It could be an indication that the baby is cold. Right? But you need to make sure that you follow closely with the baby. The moral reflex. Well, what is that? It's a reflex that a baby does, like how do they startle, how do they react. You don't need that information in the assessment of a baby in the delivery room at this point in time. The maternal history, you do need the maternal history. Like, what is the history of the mother? What's going on? So the mom had preeclampsia. So preeclampsia is related to high blood pressure. So if the mom had a history of high blood pressure, that will impact her and also impact the baby. How does it affect the baby? It could possibly decrease the amount of blood flow that's going to be going to the baby. So if there's less blood flow going to the baby, or if there's a problem with oxygenation with the mother, then that means the baby's going to be affected in regards to the oxygenation that they're receiving. And then also the mom got 12 milligrams of bechamethasone on admission. So bechamethasone is a steroid that helps to mature the lung of the baby. So that's a good thing for you to know. So right now you know the baby's 30 weeks in gestation. Right? You have a heart rate, a respiratory effort, you have a muscle tone, and you have a color. Right? So at this point in time, you have an idea about what's going on. ABGAR scores. What is an ABGAR score? And what are the things that you need for an ABGAR score? There are 5 different things that you need for an ABGAR score. At this point, being that you just walked into the delivery room, you get the first ABGAR score at 1 minute, right? Which is your appearance, pulse, grimace, activity, and respiratory effort. Right? So you don't need an ABGAR score at this point in time because 1 minute has not passed. So now we know the baby is 30 weeks. The baby has been admitted over into the neonatal intensive care unit. On the next slide, you're going to have to get some more information to decide what are you going to do with this particular baby. So all we know, the baby's 31 weeks. We know the Ellis ratio is 1.2 to 1. So we know that there's an indication that there was an issue with not having an adequate amount of surfactant, so the lung may not be particularly mature at this point in time. So you may have some difficulty with this baby in terms of how's the baby ventilating, how's the baby oxygenating at this point in time. So in the next slide, there's some more choices, because now your situation has changed. First, you were in the delivery room, and you wanted to find out what was going on with this baby. What's the gestational age? What is the history of the mother? How do I need to work with this particular baby? Now you're in a different location. So what you would do in the delivery room is going to be different than what you would do over in the neonatal intensive care unit. So you need to find out some new information about this baby. So arterial blood gas. So if the baby just arrived over into the neonatal intensive care unit and the baby's placed on the radiant warmer there in the neonatal intensive care unit, the first thing that you're probably not going to do is get a blood gas, because first you want to do is stabilize that baby. But the blood gas can be ordered. So once the baby is stabilized and you put the baby on some type of oxygen device, or you're going to intubate, or you put the baby on CPAP, then you can go ahead and obtain the blood gas. Because the baby's already stressed out from the delivery process. So the odds are that blood gas is going to be probably like a respiratory acidosis and probably some metabolic component as well, metabolic acidosis. So if you got that blood gas right away, you're going to be treating a situation that may have to change. So you might as well wait to stabilize the baby and then get the blood gas. So the reflex irritability. That's part of, that's a grimace. So when you do the reflex irritability, you're taking like a suction device and you're suctioning out the baby's nose. So if you put something in your nose is going to crinkle up, or you should sneeze, you should react to that. So the same thing should happen with the baby. So with the reflex irritability, with the grimace, the baby didn't sneeze, the baby didn't do anything, didn't react, just kind of pushed his nose up a little bit. So and the ABGAR scores, that would be a 1. So that's the other thing that was missing. So in that last scenario, when the baby was in the delivery room, if I asked you for an ABGAR score, you wouldn't be able to give it to me because you were missing the reflex irritability. Now that you are in the neonatal intensive care unit, you really don't need to know this. It's not going to really assist you in treating this particular baby, but it's not going to harm the baby either. But you do want to know what the heart rate is. Now the heart rate is up to 150 beats per minute, because before in the delivery room was only like 90, 92. But what does this kid look like? What does this baby look like? And that's one thing that's really important to us, because your clinical assessment really works with looking at the kid or looking at that patient. What does that patient look like? By looking at that patient, you're going to find out a lot of information. So what is the general appearance? The baby has nasal flaring. Baby has grunting. So nasal flaring is the widening of the nares, and the baby's trying to get more air in. Grunting is a sound they make on expiration. Once again, they're trying to create their own PEEP to keep those alveoli open. Alrighty. And intercostal retractions are noted as well. So this is a sign that the baby is having some respiratory distress. A urine culture. Do you really need a urine culture? No, you don't need a urine culture. Respiratory rate. You do know what the respiratory rate is, because the last time the baby was gasping in the delivery room. So what is the baby doing now that the baby's in the neonatal intensive care unit? So it's 72 breaths per minute. We know that a baby's normal respiratory rate is between 40 to 60 breaths per minute. So this is a little elevated. Right? So this is another indication that this baby's in distress. What are my breath sounds like? So the baby was in the delivery room. Now the baby has made it over to the unit. Do I have bilateral breath sounds? If I don't have bilateral breath sounds, what could it indicate if I don't have bilateral breath sounds? So you need to know what your breath sounds are. So they are bilateral with fine inspiratory rails. What is the temperature? Temperature is very important for a neonate, because you don't want that neonate to become cold stress. If the baby becomes cold stress, then what will happen is the baby can revert back to fetal circulation, which means your foraminal valley and your painted ductus arteriosus would reopen again for that particular baby. Then you would have right to left shunting. That's going to then affect the oxygenation for that particular baby. So you need to make sure that you maintain appropriate temperature for the baby. What is our role in that as respiratory therapists? Our role is making sure that any equipment that we use for that baby is set properly, so therefore we're not adding to the cold stress. Our role is also, when that baby's on the radiant warmer, is looking to see whether or not the sensor, the temperature probe, is on the baby and it's in the right location. Even though it's maybe something that you may not put on, if you work in the NICU, you can make that part of what you do. You should make sure that that sensor, the temperature sensor, is definitely on the baby. Saturations. Well, right now the saturations are 89%. The baby's on 50%, 5 liters per minute blow by. So when I say 50%, 5 liters per minute blow by, I mean that the oxygen tubing is hooked up to a blender. It's set at 5 liters per minute, and I have the blender dialed in to 50%. Right? Each neonatal intensive care unit is different in terms of having a blender and using it this way. Some units may just go directly from the wall and let it flow at 5 liters per minute. Others will use the blender because they're concerned about oxygen toxicity for that particular baby, in particular the premature baby. So a chest x-ray. Once again, the baby just arrived, so that could be something that's ordered. So once the baby is stabilized, you would want to know what your chest x-ray looks like. What is the weight of my baby? Because if the baby is born prematurely, and you have to consider giving surfactant, you need to know the weight of the baby if you're going to give surfactant. If the baby has to be intubated and placed on a mechanical ventilator, you need to know the weight of the baby so you can stay in an appropriate exhaled tidal volume range for that particular baby. So the weight is important for you to know. So the baby's 1,800 grams or 1.8 kilograms. And the serum glucose, it's pending. And that's something else that you also need to be aware of, because if that's too low, that could add to the stress of the baby, and eventually if it remains too low, it could also cause some brain damage to the baby. So this is our chest x-ray. So they obtained the chest x-ray. It's just showing on the baby some fine consolidation in both lungs, which is consistent with RDS. You may have that reticular granular pattern on the x-ray that you would see with the RDS patient. The heart size is normal, and this has the nasogastric tube that's in the correct position. So if I can do this right, it's coming down here. This is your nasogastric tube right down here. So the baby is started on ampicillin and gentamicin. Well, why are we starting the baby on ampicillin and gentamicin? Most babies that are brought into the neonatal intensive care unit, they want to rule out sepsis for that particular baby. Right? Each unit may be slightly different. There may be a different type of antibiotic that they start in your particular unit that you work in. But most units may use, for example, ampicillin and gentamicin. So they start them on the antibiotic until they rule out sepsis. If not, if they wait until sepsis occurs and then they try to treat the baby, usually what happens is that sepsis is so advanced that the mortality rate for these babies are a lot higher. So, of course, there's always risks in giving a medication because there's always side effects with every medication that you give. But it's less of a risk to give the antibiotic to that particular baby and then rule out sepsis and stop it or change it once you know what what the baby has. Umbilical artery catheter and umbilical vein catheter has been placed for this baby. And now this is the arterial blood gas. So 30 minutes after being placed on the radiant warmer, the baby has been assessed, the baby has been stabilized, they put in a UAC, a UVC line for that particular baby. Probably they've also put in an IV access if they want another IV access. And you have placed the baby on a 60% nasal CPAP plus 6. So your nasal CPAP, you could use anything that you want. You may use a NeoRam cannula in your institution. You may use binasopharyngeal prongs in your institution. You may use an infant flow generator in your institution. Whatever device you utilize to obtain CPAP, that could be your choice in terms of where you work. Each of them have the pros and cons when it comes to the different types of CPAP. And if you read a lot of literature out that way, you'll see pros for one and cons for the other and back and forth. So this is something that you should educate yourself on to help you be part of that conversation to know what's going to be best for you and your particular unit. Right? And this is the blood gas. So the blood gas is 7.20, 72, 58, 18, and -7. So this is a respiratory and metabolic acidosis. So now the physician wants your assistance because this baby has to be intubated. So just kind of think about it. What size endotracheal tube would you want for this particular baby? The baby is 30 weeks in gestation, and the baby weighs 1,800 grams. So what size endotracheal tube would you want for this baby, and where do you secure it at the lip? If you don't work in a NICU, but you work in a community hospital or you work in a hospital that does not get a lot of babies, this is information that you should know and keep it in your back pocket, because you never know the hospital that you work at when you get that call that there's a baby in the delivery room and they want you to come down to be part of that process. So this is one thing that you definitely should be aware of in terms of the size of the endotracheal tube. So this is a little chart that you can look at. So being that my baby is 30 weeks in gestational age and weighs 1,800 grams, you're going to use a 3.0 endotracheal tube. And where do you secure it at the lip? You usually use 6 plus the weight in kilograms. So if the baby weighs 1,800 grams, that's 1.8 kilograms, so it'll be 7.8 at the lip for that particular baby. So this is information that would be very beneficial to you no matter where you work, because this is something that you may have to use if you have a baby that comes into your hospital. So we now know that the baby's intubated. You've assisted with the intubation. The baby has a 3.0 endotracheal tube. It's secured at 7.8 at the lip, excuse me. So now you have to do something more. Your ventilator settings. Which option would you want? Option number 1, option number 2, or option number 3? And just kind of look at the different options. So we know the baby is premature. Right? So if the baby's premature, you may have problem with oxygenation. Okay? You may be concerned about oxygen toxicity. You may be concerned about ROP, retinopathy of prematurity, so that relates to the eyes, so you have to be careful about using too much FiO2. Whenever we ventilate a person, whether it's a neonate, a pediatric, or an adult, you're always thinking about barotrauma and volume trauma. So you're trying to use the lowest possible pressure and the lowest tidal volume for that particular person in order to have effective oxygenation and ventilation. So as you're looking at your settings here, look at which option do you think would work best for this baby. That one would minimize the barotrauma, volume trauma, one that would minimize the oxygen toxicity for that particular baby, alrighty, but also result in effective ventilation and oxygenation for that baby. And it's slightly difficult. Let me rephrase that. Right now I have up here time cycle pressure limited. You may use pressure control in your hospital. You may use volume guaranteed in your hospital. You may use pressure regulated volume control. So there's what I have found in my work as well as in the research, there is no consistent consensus when it comes to the type of ventilation and the mode of ventilation to use in the neonatal intensive care unit. What I have found, it really seems to depend on the unit that you work in, the neonatologist that you work with, as well as the respiratory therapists that are in that particular unit. And sometimes as respiratory therapists, we disagree on which type and which mode of ventilation would work best for a particular baby. So I just started with time cycle pressure limited, and I put the mode of SIMV and pressure support for all of them. Right. So in terms of option for our particular baby, the baby last was on 60% nasal CPAP of 6. Sometimes people think when you start out with that 6 of PEEP that you have to have 6 of PEEP when you go to be when you intubate the baby. Each hospital is slightly different. It could be the protocol in your hospital that whatever PEEP they're on CPAP, that you have to place them on that same PEEP when they get intubated, right? Most times it's going to be anywhere between 4 to 6 in terms of PEEP that you're going to start out when the baby's intubated. So the PEEP is the same across the board. What I made different was the FiO2. Right? So if the baby is on 60% in CPAP of 6, I'm just going to go back one slide. The PaO2 was 58 for this particular baby. Right? So we know in terms of PaO2, we want our range to be between 50 to 80 for the PaO2. A lot of times they may say stay on the lower end of that 50 to 80 for a premature baby. So when I say on the lower end, more towards 50 to 60 in terms of PaO2, maybe 70 the most. And then for a term kid, we go on the other end, 60 to 80 or 70 to 80. So for this premature baby who's 30 weeks in gestational age, their PaO2 on 60 was 58. Right? So you don't need to go up to 90, because that will be way too high of an increase, because you're already there in the ballpark. But you don't know whether or not this baby was a little bit traumatized with the intubation. So we know we definitely don't want option number 2. So now we have option number 1 and option number 3. So we have 65 and 70. Well, either one is not too bad, so let's keep going down the line. Our inspiratory pressure, we set at 14 for option 1. For option 3, we set at 12. Right? And then going all the way down to tidal volume. For the tidal volume, for option 1, it's 12.6. For option 3, it's 9. Right? Normally in the neonatal population, you want your tidal volume range to be between 4 to 6 mLs per kilogram. Right? So if you are in that ballpark and you can achieve that tidal volume at a lower pressure, then go with like option number, you can go with option number 3 potentially. If you go with option number 1, alrighty, if you did that particular option, you're starting out with a higher pressure. So you may cause a little bit more barotrauma for that baby. So you would have, I would probably go more towards the option 3, even though I have a little bit higher FiO2. Someone may disagree. They may say, you know what, I'd rather go with the lower FiO2, minimize oxygen toxicity, and then open up the alveoli and then drop my PIP down. So either 1 or 3 could be a choice for you. The ventilator that I'm using, my hypothetical ventilator, my inspiratory pressure is above my PEEP. So that's why I have here inspiratory pressure 14, my PEEP is 4. So the total PIP that this baby is receiving on option 1 is 18. For option 3, it's 16. Right? Most of the literature talks about keeping the PIP in between 15 to 20, so that's the total PIP. So both of them are in that range, but option 3 is a little bit of a lower PIP. In terms of target blood gas ranges, this will vary based on the hospital that you work in and what is their protocol. But these can be guidelines for you in terms of where do you want to keep that pH, where do you want to keep the CO2, where do you want to keep that PaO2 for that baby, as what is the saturation range. Right? So what's important for you to know, if you work in the NICU, what is that particular range? If you don't work in the NICU and you have that baby that comes into the delivery room, that comes into your emergency room that's born prematurely, this could be a starting point for you. This is a starting point for you to say, okay, at least I know that this 30-weeker, that I want to keep my saturations between 88 and 92. So if my saturations, once the baby's born and stabilized and on the ventilator in the emergency room, for example, and if my saturations are only 85, then I need to do something to increase my saturation for that particular baby. So this is a starting point. In terms of PPHN, which is persistent pulmonary hypertension of the newborn, for that particular one, typically you want it just a little bit alkalonic and the oxygenation a little bit better. because with these types of babies, the concern is reverting back to fetal circulation. These are babies that tend to be your full-term babies or close to full-term babies, and they get cold stress, they end up with acidosis, they have problem with oxygenation, there's something else that's going on that causes them to go into PPHN. Usually they have something else, whether it's meconium aspiration, congenital diaphragmatic hernia, for example, that will cause them to go into PPHN. So babies typically are not born with PPHN, they tend to develop it after birth. So those babies, you keep them slightly alkalotic, the oxygenation a little bit higher, then what happens is you minimize the risk of the baby going back to fetal circulation. So the baby was intubated, placed on a mechanical ventilator. They gave the baby some surfactant, and an arterial blood gas was done. So now the baby's on 80%, a rate of 60, a total PIP of 16/4, and there's a pressure support of 8. When it comes to pressure support, I would just say, and we could probably have a long discussion about this, when it comes to pressure support, just remember one thing: how on your mechanical ventilator that you're working with, when you set that pressure support, is it above the PEEP, or the number that you set in, is that the actual pressure support that that person is receiving? So this is whether you're working with a neonate, pediatric, or an adult patient. Because some ventilators, most of them nowadays, the pressure support is above the PEEP. So for example, if I have here pressure support of 8, does that mean that I have 8 set on the mechanical ventilator? If it's above the PEEP, then the total pressure the baby's getting for those spontaneous breaths are 12. Right? So that's just something that you need to remember, or you may already know, is that if you have written 8, and that's what you have on your chart, you need to look to see if it's 8 on the mechanical ventilator. If it's 8, you need to keep in mind that it's 8 plus your PEEP, because it's going to be above the PEEP on most of the mechanical ventilators. I tell you that because usually what happens is you want your pressure support, your total PIP, to be lower than your total PIP of your mechanical breaths. Because you want that baby to work just a little bit. Some people will say, no, I don't want my baby to work. You know, I want my PIPs to be closer. Once then that becomes a preference of the unit that you work in. So now this is our blood gas for this particular baby. Now we're doing better. We're down to up to 7.34, 48, 78, 20, and -1. Our heart rate is 150. Our total respiratory rate is 60, so we're set at 60. And the baby is not doing anything above the ventilator at this point in time, and the saturation is 90%. So I have 3 different pressure volume loops here. Loop number A is the most recent pressure volume loop after administration of surfactant, and it's showing you that it's a good compliance here. So if you had this pressure, if this is a previous pressure volume loop here, this is showing that this is a decrease in compliance. So when it comes closer to the pressure axis, that's showing that's a decrease in compliance. The other pressure volume loop, which is here, that's showing you that this is overdistension or beaking. So with overdistension or beaking, it's letting you know that you have a higher pressure, but you're not getting any additional tidal volume. Right? So what you potentially could do, you potentially could lower your PIP down, but sometimes what you have to remember is that sometimes those babies want that higher PIP, even though they're not getting any additional volume, because that's that opening pressure that they need to keep those alveoli open. So you can try lowering down your PIP on your mechanical ventilator in order to get rid of the overdistension or beaking, but sometimes you may have to go back up again. So now, this is what's going on with the baby.